Well, I will continue on that too a little bit. I will focus. I didn't look on my data on the number of chromosomes, on the type of chromosome involved. I make a note to check that once back again in Spain, okay? But I take care of the partial deletions, and that I see that something is happening there too. I will show you. This is the set already, so I quit. One thing that I have to say is that, to me, this is not a prioritization technique. To me, it's a diagnostic technique. I don't tell my patients that it is to prioritize the embryos. I tell my patients that it is to detect if the embryo is okay or not, as I usually do with a standard PGT, with a tropho PGT, as we said, and no measure or tropho. Why? Because then you will see the reports that I got from Bioarray. In the reports that I got from Bioarray, there is no appearing the percentage of aneuploid or the chances of Euploid. It says only what they say, what they see in the medium. There's no interpretation. Okay. If I tell the patients that this embryo has an 80% of chance to be Euploid, is that I don't believe this technique. So if I don't believe this technique, why I should use this technique to my patients? And I know that, and we speak of that later on, that there is not 100% of concordances between the media and the tropho. Okay, but as Luis said in the beginning, it's neither 100% of concordances between the tropho and the muscle stem cells. No, you said it's a 97%. I don't think so. I think it's a little bit lower. Okay, some data says up to 80%, 80-90%. So but this is really well known. There's no data on that yet, but will happen. No? So if I think that in the tropho, in the media, it's 80%, which one is good? I assume that the good one is the trophoctoderm, but I know that the trophoctoderm is not as real as the internal cell mass. So I put them in the same level. So I tell my patients that the sensitivity of this technique, tropho biopsy or non-invasive biopsy, is the same or similar, which is what data said. But if similar, if it has no risk for the embryo, people get it. In fact, all the patients ask for that. And I do now only for frozen embryos. And now when I told the patient that in fresh embryos I don't do yet, they want to do also non-invasive in fresh embryos, because so I'm doing it now. So anyway. And moreover, I think the information that we will get for the embryo, for the non-invasive, will be much global, because you do not only get information from some cells, but from the all altered embryo. Okay, so this is my feelings. So most of the patients, and when they ask me the price, I tell them that it's the same price. I don't know if it's like you or what. They're happy to know. They expect to be more expensive. I don't know why. They expect to be more expensive. And to me, it's the same. So this is the information that I get from Bioarray. A number of embryo, day of liquids recovering, and the alteration that they find, and alterado. What they put here in Spanish said, esa columna no es un diagnóstico. So they don't make a diagnosis, but they tell if it's normal or abnormal, and according to that, and that's what they do. If it's normal, I put. If it's not normal, I don't put it. Except in these cases, duplications. If I see in the embryo a duplication, and only a duplication, this one I also have a chromosome 22 less, okay? This one I won't put it. But if I only see duplication, I make a re-biopsy. So if the embryo was analyzed with non-invasive, it's frozen as non-invasive, I warm it up, I make a trophectoderm biopsy, and freeze it back to see if that's real or no. And some of the cases, yes, only segmental. Only segmental. I repeat it, and I have done it not many times because it's very fresh data, no? But from 3 that I remember, 2 were okay. One had this one and other alterations. in the trophectoderm biopsy, okay? So these ones I don't discard. I just put apart. If these embryos the good embryos don't go further, I then rebiopsy the segmental, okay? Also with mosaicism, well, in fact, here there's the mosaicism, but it's there anyway, no? But we don't know. As we said, if it's less than 50%, they consider normal. If it's more than 50%, but so we don't see mosaicism, I will see the result itself. So this is the same criteria as normal. I apply the same criteria. If I have a normal trophectoderm biopsy that has a duplication, I warm it up, but then I do non-invasive in order not to do 2 biopsies in the same embryo. So if it's a biopsy of trophectoderm, I have to repeat, I do non-invasive. If it's non-invasive the first time, I do invasive in the second one, okay? So this is the data, 150 embryos tested, okay? 50% of them were euploid, which is good. Amplifier failure around 4%, which is quite a standard. And some of them, okay, 40% of euploid. And if I look to the alterations, 30% of them only showing deletions and duplications. Only. Here we have embryos with trisomies, monosomies, and moreover, duplications and deletions. That, to me, these embryos are not good, so I don't care if more than a trisomy has also deletions. But here, there are 30 embryos only having this kind of alterations. You see, make myself understood? So this is ones that I possibly do rebiopsy, 30%. If I look, I try to understand why I have these high values of embryos having partial alterations. If I look to the data of my patient, most of them are young women. I ask, I do PGT on request. Finally, as you said, Raluca, people come, I offer them embryo donation, I offer them double don, which are young woman, a young donor, and they ask for the PGT. I said, okay, it's not mandatory. But if you want, you do it. And they ask for that more and more. And this is not a standard in Spain. Embryo donation with PGT, it's not a standard in Spain. I think that nobody does. I do. And because they don't want, I don't care. I mean, for me, it's logical. If I were a patient, I wanted to have an embryo as good as possible, which makes sense, no? So, well, 80% of my patients are young patients. Also with double don, embryo don, and egg donation. If you look at the data, depending the age of the egg, okay, we see that obviously a younger woman has more euploid embryos than elder woman. Makes sense. And also similar amplification failure. Here the data is lower, so well, it makes sense, no? If you look at the type of alteration, again, trisomies are quite similar, okay? But we can find more duplicate alterations in young woman than in elder woman. Chaotic also, it's higher, which is makes sense. Older woman has more problems, so we have more alterations here, no? But what is shocking is this data, okay? Why in this in young woman we have more, but also only means that all the karyotype is normal, but we find some partial duplications. Why is that? Why did I find that in young woman? I don't know. If you remember from my first slide, when I use frozen embryos, I put two types of culture. If the embryo was day 5, I put it overnight. So it was 10, 20 hours. If the embryo was day 6, I put only 6 hours, not to put the embryo on up to day 7, okay? And most of the cases are day 5, but also have day 6 embryos. I split the results, look into that, if that makes sense or not. Day 5 embryos have less euploid than the 6 embryos. Makes sense. So if I have at the 6 embryo, always it's known to have more alterations than at the 5 embryo. So I see that. And the vertical failure, it's higher here. If I put the embryo, well, it's, yes, I mean, higher. I know the numbers are low, but perhaps putting the embryo not a lot of hours increases the amplification failure. That's what Raluca was also seeing. Raluca was putting day 5 to day 4 to day 5. She was looking for more amplification failure. I also saw the same, only with 6 hours culture. Makes sense. But this is what I was not expecting. The embryos in day 5, that I put them 20 hours, have the double of deletions and duplications that embryos, day 6, worse embryos, less time. So the more time I put the embryos in culture, more deletions, replications I find that probably are not real. Is what you're also thinking, okay? But I don't see that with low culture. Sorry. Well, yes, I see it, but much more, the double. Even the numbers are not compatible, but the chaotic, it's quite similar, okay? But not this. So what I'm thinking is that this extent of culture may produce artifactual amplifications. I don't know if it's artifactual due to amplification itself, or it is real that the embryo puts away the thing. But when I make a second biopsy, I don't see that. I mean, I don't know. It's data that I have and I share with you, okay? But I don't know. I have an answer for that. That's it. Well, I mean, to me, the non-invasive, it's a way to go. To be honest, it's difficult when you start something and nobody believes on that, okay? And everybody continues doing the PGT, Tropha PGT. In fact, if you go to Esre tomorrow and the next days, I don't find any talk speaking about non-invasive. Perhaps there's some poster, but not in the program. There's no talk about non-invasive. Strange. Because this Embrace that do that with a strong marketing position, and nobody publish on that. Why? I think that people don't want to change something that works. If you have in your laboratory the standard PGT, the laser, everything that is set up, why to change to something else? This is also energy for the team and money, after all, okay? Because for the validation, I did, I don't know, more than 200 embryos for validation. I am still doing validation for fresh embryos, and it is money. Even though Bioarray makes me a price, it's money. It's money, and I think this is the future, because I can have the same information, or even better, with no harm on the embryo. It's the way to go. But perhaps you have to understand much more. We have to understand if you have to believe that or not. We have to understand you have to believe the embryos, the big chromosomes or not. And we have to understand in which moment we have to put the embryo. That's what you do differently. I do as you. I put day 6 embryos on day 5 endometrium. But I think that you should go in that direction. Or doing day 4, day 5, but I'm afraid to lose amplification. But perhaps I will gain sensitivity, I don't know. But or doing day 6 and putting embryos on day 6. I have to study that. But we have to grow together with the technology. This is not a standard protocol. We are doing the protocols ourselves. And when you do a protocol yourself, it's a little bit, it's a test error that you have to do. But you have to analyze the data, understand the data, and be critic to yourself. Well, anyway, this is our data, and it's something that, well, shocks me. Thank you.